It is just a huge honor for me today to be podcast interviewing Sherman House. DDS is currently in his second decade as a healthcare provider and is a hospital dentist and assistant professor of oral and maxillofacial surgery at the Meharry Medical College in Nashville, Tennessee. Prior to his career in dentistry, Dr. House was a fireman and emergency medical technician in Washington State. Concurrently, he was an armed guard for several West Coast armored truck companies. He holds undergraduate degrees in law enforcement from Skagit Valley College and also biology and philosophy from Gonzaga University. The editor of Dental Town magazine, Tom Giacobbe, his kids all go to Gonzaga University. He completed his Doctorate of Dental Surgery at the Meharry Medical College with honors in Nashville. He earned a hospital dentistry certificate as a chief resident from the Metro General Hospital in Nashville. After a decade in private practice, Dr. House joined the faculty of the Meharry Medical College in the oral surgery department, where he works as an assistant professor and attending DDS. Dr. House also teaches a tactical combat casualty care-based first responder course called Hemorrhage Arrest Course to lay people, law enforcement, and military professionals. Hopefully he'll put that on Dental Town someday. He also teaches open enrollment wound closure and dental emergency management courses to lay people and other allied healthcare providers that lack direct dental experience. He is happily married to an attorney and yoga entrepreneur, and they have one 14-year-old boy. In his free time, Dr. House enjoys playing rugby, practicing Brazilian jiu-jitsu. I take it you're a Horace Gracie fan.
Yes.
Yeah, and cycling. He's my gosh, wow! What an exciting, diverse background. I was looking at your website. I don't want to get too off course here, but found your civilian defender. He's got a website called civiliandefender.com. Before we get into oral surgery and teeth and all that, what is the civiliandefender.com?
Well, thanks for having me, Howard, first off. Civiliandefender.com is a website that I started probably about 6 years ago. And I guess people would call it a blog now. I always just call it like an essay site because I don't put stuff up there, with, Gregorian regularity. I just kind of put stuff up there when I have something useful to say. And then I also use it to promote a lot of my open enrollment classes and that I teach. So a few years back, when I was, I haven't always been in dentistry. I've had kind of a varied experience in my past, and a lot of that involved, being an armed professional of one kind or another. And so that website is kind of an amalgamation of all of the things that I've learned through training and experience, over the past 20-some years. That I try and, pass on to my students and the readers.
So you were born up in the state of Washington near Canada.
Yeah, correct. Yeah, my dad was a naval aviator, and so I was born at the Naval Air Station on Whidbey Island.
Wow. So so you've been in military. So that's where the roots of that civilian defender come from, right?
Correct. Yeah. I mean, when I originally left high school, I had every intention of, being a police officer, and ended up kind of sort of pivoting and going into the EMS. But I've always had kind of a interest, in public safety and public service.
That is very interesting. My gosh. From your civilian defender to oral surgery, it sounds like you've always been a hands-on surgery, wounds, surgery, suturing.
Sure.
Has it really changed a lot in your lifetime? I was hearing on the news, maybe a couple of years ago, that now there's some chemical pack they pour in a wound and then it sets up and coagulates. Has there been a lot of technological advances in your career for these civilian wounds and stuff like that?
Yeah, unfortunately, probably one of the most beneficial side effects of the global war on terror has been, the advancements that have been made in trauma medicine, that have kind of trickled down into civilian emergency medical services. And yeah, there's like, quick clot, combat gauze, things like that are, available like on Amazon or, at REI even. You can buy these things if you're like cyclist or mountain biker, if you have, uncontrolled bleeding, a tourniquet and some wound packing, with a hemostatic in it is what saves people's lives. And it happens very regularly now. So.
You got a 14-year-old child. I want you to put your dad hat on first, because we have a
Sure.
reoccurring problem in dentistry. Everybody talks about, when they talk about the 12 dental specialties, number one is always oral surgery, highest paid everything, and endodontics, and then it's perio, pediatric, ortho, pros, dental anesthesia, oral facial pain, oral medicine, oral path, oral radiology, and the bottom is dental public health. And whenever I talk to a dental public health person, they say one of the 8% of the emergency room visits are odontogenic in origin. And they always say the major problem is that someone will go to a dental office and that dentist went all down the road of cosmetic dentistry, bleaching, bonding, veneers, and Invisalign, and they can't pull a tooth or do a root canal. And I mean, my gosh, I hate to be rude, but you're really not a doctor if you can't treat a wound, pull a tooth, get them out of pain. And I couldn't imagine, you're a cycler. Could you imagine wrecking on your bicycle? They take you to the hospital with a broken leg and they go, sorry, Sherman, we don't do legs. We just do fingers and toes. I mean, and when I talk to them, there's two paths out of dental school. One is the most needed, most profitable, and it's blood and guts. It's I can pull this tooth and start a root canal. And half the class says, nah, I want to do the bleaching, bonding, veneers. And I say, why? You got $400,000 student loans, and it's fear. It's just fear. So put your dad hat on. What would you say? She's in dental school. And she pulled a tooth, she did a root canal, and she's like, you know what, I could live 3 more lifetimes and never do that again. How do you psychologically pump up a kid? Because I know after they do 100 extractions and 100 root canals, they're past it. But crossing that chasm, how do you get someone afraid of blood and guts to pull some teeth and start some root canals and do your public health dentistry service and stop throwing them all? In fact, when dentists tell me, don't you hate it when people say we're not a real doctor? I said, well, you're not a real doctor. Because if you crash your bicycle on a Sunday, the ambulance is working, they're taking you to the hospital, they're all working. You could find 3 mermaids and 4 unicorns in Phoenix on Sunday before you found a dental office open. And then 8.5% of the emergency room visits, blah, blah, blah. So how do you get a young child in dental kindergarten school to get over the fear of blood and guts?
Well, I do it a couple different ways. And I always tell people, when people say that, you're not a real doctor thing, I say like, no, I'm a real doctor. Like I do surgery every day on people's heads. What could be more important than somebody's head? You're less than 3 inches from their brain and 6 inches from their heart. So yeah, pretty important. But, with students that we have, in the clinic at school every day, and I work in the dental schools, outpatient oral surgery clinic most of the day. And, we have probably between 3 to 5 third or fourth year dental students that, get vasovagal and pass out every week. And that's either from, the extra layers of PPE and the heat exhaustion, that people are experiencing now with all the extra COVID precautions, or, intermittent fasting, or one thing or another that results in them kind of getting hypoglycemic and a little wobbly. So I get other students to kind of sort of, I always say, like, galvanize themselves or gird up their loins to be able to deal with people passing out, because that's one of the most frequent, inter-office dental emergencies that we deal with is, syncope. And so that's kind of like one thing that I hit everybody else on. And so they get to see like what it actually looks like to put somebody into the Trendelenburg position, and, see what it looks like to get high flow O2 onto somebody that's passed out, and get them, back to where they're functioning and alert and aware. The other thing is that, I try and get people over the idea really quick that, dentistry is a bloodless specialty, or subspecialty. I mean, there's nothing bloodless about it, even on the most atraumatic, orthodontic extractions that you might do on primary teeth for a teenager or a child, there's still going to be a tiny amount of blood, even with, no flap and very little manipulation. But there's always going to be some blood, and some people, are geared for that kind of thing, and some people aren't. But yeah, I agree with you 100%. I think that, I know that we don't require people to do, a residency to go into practice. And I really think that so many of the students that I see would benefit greatly from, a GPR or an AEGD, not because they didn't get a good dental education wherever they went, but they need the basis in dealing with when procedures don't go well, like when there's complications, when there are emergencies and things that fall outside the realm of conventional dental curriculum. And so those are the things that I try and prepare people for. And I always encourage the D3s and the D4s, like, to think about doing, a hospital dentistry program or an AEGD if they're not really into, dealing with the medical complexity stuff so much. Just because I think it's that important. And these days, I always enlist the help of, other medical specialists in guiding, treatment plans for especially medically complex patients. And I conduct myself in such a way that, I want those physicians and cardiologists and whoever they might be to think of me as, a subspecialist, just like they think of themselves. And I teach my students, and residents, if you conduct yourself in that way, then that's how you'll be treated. And I kind of get miffed, when I see the, social media has done a lot to promote the purely cosmetic and almost gimmicky side of dentistry. And, people ask me all the time, like, hey, what kind of whitening products should I use? And I said, I honestly have no idea. Like, there's people that deal with all that stuff, and I'm not that guy. Like, I'm the guy that if you want to, you're interested in getting a couple teeth out, but you also have hemophilia, like, I'm the guy that you're going to come to, So that's kind of my take on those things. But I agree with you 100%. I mean, I've been the guy before on, transcontinental airplane flights, when they've said, is there a doctor on board? And I've raised my hand and stood up and, rendered aid to people just like I would any other time. So yeah, I agree with you 100%. I think it's the emphasis that needs to be put on being able to treat people in an emergent state, or how you find them, is absolutely, absolutely critical. And as kind of an addition to that, right now at Meharry, where I work, we're trying to put it, everything is so partitioned, having to do with CODA, as far as hours that are allotted to certain subjects, but I'm trying to squeak an extra 4 hours in so that I can get the residents and the students 4 hours of tactical combat casualty care based training, so that, if they're at a peaceful demonstration and violence breaks out and someone has life-threatening arterial bleeding, or I've had 2 patients in my practice in the past that have had gunshot wounds that needed immediate treatment, and they came to the first place where they thought they could get some medical help, and they luckily, coming to my place, they came to the right place. But yeah, I think that kind of training is absolutely essential, because you will not, you will respond to the way that you were trained. And if you haven't had that training before, you are not going to do it.
And I've got some roots to you and Meharry and all that. So you can't even make this up. This is so bizarre. But the two oral surgeons at my school at UMKC, which, by the way, UMKC, Cesar Sabatez just got elected to become the 88th president-elect. He's a UMKC graduate of 1987, and he'll be the first Cuban-American, the first Hispanic-American to be the president of the ADA. But when we were at UMKC, the two oral surgeons were Charles Williams and Brett Ferguson, and now his daughter, Daphne Cassandra Ferguson. That's Brett Ferguson's daughter, right?
I'm not positive about that. I know that we have Daphne Ferguson Young that works. That's the director of the GPR clinic, but I'm not sure if he's related or not. Charles Williams, though, I know him for sure. He was actually my professor of oral surgery when I went through dental school. And he also was the guy that interviewed me when I came to Meharry.
But I was bringing up Charles Williams,
Mm-hmm.
and it was two things that come to mind. There was a girl in the class that was an assistant, and her name was Susan. Susan, God, maybe her name was Susan White. And I would see Charles Williams and Brett Ferguson, these big old manly men, and I thought oral surgery was about muscle and all
Strength.
that stuff. And then I watched this little Susan girl, who she would just sit there and she wasn't sweating, she wasn't grabbing hard. And man, they taught me everything about leverage. But when you said about the peaceful demonstration, I got a strongly worded lecture from Charles Williams, and it changed my course. In the oral surgery department, someone was, they'd gotten in a fight or an altercation or a gunshot or whatever, and we're in the working case. I'm asking about all this stuff, and he stops. He goes, "Look, right now, they're in the oral surgery department, and they need an oral surgeon. They don't need a judge, a jury, a preacher, their mom, their dad,
Sure.
whatever. And you just need to stay in the zone, because if you start thinking about all that stuff, your surgical skills will go down." And he said, when you're in the oral surgery department, let's do oral surgery. And I don't want to know who did what, who started the fight, what they're demonstrating, whatever. You just get our job done. But my gosh, I thought Charles Williams and Brett Ferguson were just the two most amazing people at the school. You dropped the name CODA. I'm afraid a lot of people don't know what that CODA means.
Oh, that's the Committee on Dental Accreditation.
Okay. Your last, one of your posts on Dental Town is actually what we were talking about. You said she went to the ER last night. The ER doc gave her some Percocet, blah, 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 blah. And then you're showing these pictures of something that's just such a mess. I couldn't imagine that this patient went to the emergency room and their best idea is Percocet. And what I think strange about hospitals is you go in there, they can remove a tumor out of your brain, they can do a bypass, they can amputate your diabetic foot. And then when they look in the mouth, they just hand them Penvk and Vicodin. Is that changing? It seems to me the infrastructure at American hospitals is wrong. If I could, take out a bullet and a tumor and cut off your foot, but I can't. This picture you have on here, it's like, are you kidding me that a doctor looked in that mouth and gave her Percocet antibiotics? Is something structurally wrong with hospitals when they can't do an entire body part?
Yeah, I think there is. And one of the great things about being here, is Metro General Hospital is on the campus of Meharry. We're one and the same. So when, a dental chief complaint comes into the ER, they call, the hospital dentistry department or the oral surgery department to, go in and do a consult and get to the bottom of it. And so we have a little bit different approach here, but a lot of the emergency rooms that are in Tennessee that aren't us, they do that. They'll give somebody maybe a Toradol shot and some and some antibiotics or some clindamycin, maybe some amoxicillin, and send them on their way and just say, "Oh, go ahead and follow up with a dentist." But I've seen a few of those people that have been patients that are there when we open the doors at 7:50 in the morning, and they're a fascial space infection, so they miss the pickup a lot on some of the odontogenic and even orthognathic issues that it's kind of strange. It's weird to me that if you have a hospital dentistry resident, they'll do rotations in the ER where they will, suture wounds, work up patients, do codes, full blown respiratory arrest or CPR codes, full resuscitations. But we never have, emergency room physicians that that are residents that come through and, learn how to shuck teeth or cut a flap or drain an abscess or do any of the number of things that we do on a regular basis. I don't know who teaches them dental blocks, but one of my friends that's an emergency room physician in Spokane, Washington, he said that a dental block is one of the highest reimbursed procedures that they do. So that might have something to do with it as well.
Another thing I wanted you to weigh in on is there are sometimes because this has been a constant rant of mine for a long time that, a real doctor has to do blood and guts. They have to be able to do exodontia. They have to get a patient out of pain. They just got to do what they got to do. And a lot of times they let the better be the enemy of best. Right now they need a doctor, they need to get out of pain, and they start thinking things like, well, I'm not an oral surgeon. But a lot of them come back with a specific that I want you to address. And they'll say, well, I would have if I was in Meharry, but I need a 22 cal, I need a cal. I mean, some of these people need like 50 different forceps to approach oral surgery. And then there was one of our teachers that taught with Brett and Charles was Matthias Horrigan. And he said, and he used to get so mad, he hated instruments. And he said, look, I was an oral surgeon in Korea, and we had a 150, a 151, a small, large elevator, and a periosteal. We had 5 things.
Yeah.
And he said, I pulled every single tooth in Korea with those 5 instruments. And then on the other side of the spectrum is somebody's not going to get out of pain because they don't have one of the 50 forceps. So my specific question to you is, how many forceps does a dentist need to be able to walk into an operatory and say, I'm going to pull that tooth come hell or high water? How many do they need?
I generally, in the room when I'm working, I'll use a 150, a 151, and a 23.
Okay,
I can
so
get
a 150, a 151, and a 23,
and a cow horn. Yeah,
and so 4 forceps.
Mm-hmm. Yeah, I mean, I can use an 88 if I have them, or a 3 if I have them, but I don't, unless they're there, I don't really even think about them. And kind of going along with what you were talking about with Dr. Matthias. When I worked for a time as a contractor for the Army National Guard, and, you'd get to a location with a portable operatory setup, and, your armamentarium was very, very Spartan, and it wasn't unusual to have exactly what he said. You had a number 9 molt periosteal elevator, maybe a 77R and a 77L. And a 150, a 151, and a 23, and a blade handle. And, if you needed anything else past that, you had a surgical handpiece, of course. But if you needed anything past that, you were going to get we don't have that, what do you think this is? It's not an instrument store here. This is what we got. Everybody else did it with this. And you'd be like, oh, okay. So, you only have to do a few thousand of those before you kind of get the moves down. And then you go back to your, regular office and go, boy, we got a lot of stuff here in, each one of these autoclave bags or these instrument kits that's just kind of taking up a lot of space. So, stuff ends up going on eBay.
Another thing I've noticed since I got out of school is we used to take the periosteal, and we just used to detach the tissue.
Sure.
And a lot of the young dentists have said to me when they're watching, they're saying, well, you put a lot of time on that area, but the tissue's not really holding it in, it's the bone. But again, Dr. Dr. Williams, Dr. Horgan, Dr. Ferguson, they always said, and I want to, that hydraulics, and what I mean by hydraulics is, if you put the Empire State Building in a test tube, you could just shove a little pencil in the bottom and lift up the Empire State Building. I mean, these hydraulics. And he used to always say, when you do that periosteal all the way around that and really get it good, you start the inflammatory process and it starts inflaming and it starts loosening up. And now I've seen that turn into proximators where if I go around with the periosteal and then I go around with the proximator, I mean, you could almost play with that thing long enough to where it'll just start coming up out of the mouth.
Sure.
Are you a big proximator fan or not really, or is it too slow, or what are your thoughts on that?
I mean, if I'm doing something where I'm really concerned with ridge preservation, then I will. But a lot of the time I can get away with just, using conventional instruments and still not having, having a minimal amount of damage to the ridge. And as far as socket preservation goes, and a lot of times, you graft immediately following. But yeah, I always, there was a time where I can't remember. I had an associateship and they did have approximators, and I experimented with those for maybe a couple months on, several hundred extractions. And the idea of either creating space or severing periodontal ligament fibers, to work to luxate a tooth is great in theory. I know periodontists love them. But I always kind of think of that as the sniping rifle of oral surgery. And, you can get a lot done with, with just a regular 77 and just a little bit of flick of the wrist and just knowing exactly where to put it. And that's one of the things that I think a lot of students get kind of twisted in their minds, is that they aren't working against the root surface in the bone. They're trying to work the elevator between two teeth, and they're ending up getting one out for sure and getting the other one half of the way luxated. And so that happens occasionally in the clinic, where I'll say, okay, this is how we luxate and watch where this goes. And going along with that, like where you said that people will use the excuse, well, I would have pulled this tooth, but I didn't have, X, Y, and Z available to me, or I didn't have a handpiece available to me. That I would say probably 8 out of 10 of the cases that we have in the outpatient oral surgery clinic where the student, will request, I need a handpiece in here and some supervision. When I go in there, I look at what the current state of the patient, and I don't use a handpiece at all. I just use a little bit of creative elevator work and just pop it right out.
Going back to that pulling out, I want to tell the kids also, when we're talking about, you go around with the periosteal, you're loosening up the ligaments and soft tissue, but you're starting the inflammatory process. And when you're elevating and there's nothing happening or whatever, and then you get more frustrated because now you're getting beeped for a hygiene check. Well, my God, that's perfect. Put everything down. Let Mother Nature start swelling and flaming and all that. Go do a hygiene check. Go to the bathroom, eat a Cheez-It, whatever. And then you'll come back, and if you're out of that room for 5 or 10 minutes, you will see exactly what I'm talking about. When you left, it wasn't budging, and then when you get a hygiene check, you went into panic mode and thought, well, now I got to get out in 2 seconds. Let Mother Nature do the work, and then you come back and you'll see what swelling and inflammation does. It's a beautiful thing. I want to ask you another controversy. I want to. This is Dentistry Uncensored. I don't like to talk about anything everybody agrees on. A lot of these kids, again, I'm staying focused on the kids because that's really, the only value of knowledge is if you can share it. And, we should always be trying to take what we learned on our, 70 laps around the sun and hand it to the next generation. But they're sitting there, they're afraid that if they pull that tooth, they're always looking at the x-ray and saying, well, that root's in the sinus and I don't want to get a sinus exposure. But then you hear people say that 99% of sinus exposures, nobody even knows it. You
Correct.
won't see it. And then the other thing they're afraid about, it's by this nerve that they're afraid they're going to hurt this nerve or whatever. That most all the nerve injuries is because you broke off this little 2-3 millimeter root tip and your ego just can't let it go. So now you're down there digging and drilling bone and you just make a mountain out of a molehill. And a lot of these older guys, like Matt Horgan used to always say, he said, you know what? If you left that damn thing down there, 3 months later, it'd work out like a splinter, but you had to go in there and cause a parasite. So I know that's a lot of questions, but I'm afraid to pull this maxillary first molar because I'll get a sinus exposure, and I'm afraid to pull this mandibular molar because it's too close to the nerve. And,
Sure.
And that is going to make her decide I'm not doing oral surgery. So talk about that.
Sure. So, you're always going to have bad outcomes. Like, despite your best efforts, you could have the cleanest surgical technique and form. And, sometimes the patient is just medically non-compliant and you're going to have a bad outcome. And that's not malpractice. And that's where a lot of the students these days get kind of, wrapped around the axle that's not malpractice. Malpractice is when you have made a grave mistake that you should not have made, but you did it anyway, and you kept pressing on and caused some kind of damage. So yeah, that's kind of the thing about it. And, a lot of times what I will do is I always tell people, if the root tip is the size of a BB or smaller, and, which is 17 caliber. So, like 4.5 millimeters in diameter, if it's that small, 3.5 millimeters. If it's that small and there is no, periapical radiolucency or abscess or something that makes you think that there's some type of pathology in the bone, leave that thing in place. If there is pathology, in the bone, then a lot of time the bone is kind of spongy and squishy and corky, and you can flip that little piece out of there. You just have to be able to visualize it. And then as far as the sinus exposure thing goes, there's plenty of people that have, the apices of premolars and molars that are, well within the sinus, and you can take those things out with no concern at all. And if you do get a sinus exposure, the trick is you have to know how to close it. And it's not a difficult thing to learn how to do. And you also have to know the parameters of what you're looking at. So the way that I recognize, if there's been a sinus exposure and how I teach students to do it is to, just use their 27 gauge local anesthetic needle and feel up into, the socket where those teeth were, previously residing, and just kind of palpate with the needle tip. And if you poke through into the Schneiderian membrane, with a 27 gauge needle, it's not going to do anything of note. And, what you're looking for is a hole that is, larger than 2 millimeters. A hole that is less than 2 millimeters, you just close it up like you would any other extraction socket. If it's, 2 to 4, you can usually get away with, some gel foam or some type of biologic. And then past that, you're going to have to do some type of, if it's like a 6 millimeter exposure, you're going to have to do, some type of, a buccal advancement type flap or a buccal fat pad or something like that to be able to get something like that closed and have it stay closed and not turn into an oral antral fistula. But yeah, a lot of times people will come in, or students will come in for, with one of their student pool patients and have, one of my professors used to call it the Lone Ranger, standing there. That's the lone, 2, 3, or 14 or 15 and no adjacent neighbors, and say like, oh boy, even though this person has severe perio, that last 1/3 of that root structure is holding on for dear life, and it's going to bust a big piece of bone off with it. And if it does, it's not the end of the world. So I, have people, cut a full thickness flap so that they've got good exposure on the bone, and then just go real slow. And I always call it the 15 and 15. I'll push to the buckle and count in my head, 1 Mississippi, 2 Mississippi to 15, and then push back towards the palatal for another 15. And it usually only takes about 3 cycles of that. And you can get just about any tooth in their mouth out, atraumatically and with a minimum of sinus exposures.
Another problem with, again, I'm trying to focus on the, public health is about availability, accessibility, affordability. And I want to talk about that demographics. I see people talking on Dental Town. They'll say, well, I wouldn't go to Nashville. There's too many dentists there. And I'm like, whoa. There's 168 hours in a week. I bet there's too many dentists Monday through Thursday, 8 to 5 and a half day on Friday. But I bet there's not a single dentist in town on, after 6 p.m. or Saturdays and Sundays or whatever. But a lot of these people say, there's so many new prescription medications out there, and it's just endless. And Americans are 4.5% of the world's population and take half the prescription pills. And they just look at these health histories and they start going into fear mode, complications, side effects. How do you get your mind around the health history, with all these medications and interactions? And, what is your simple, do you have an app? Is there a website? How do you get around that?
I do a couple things. So I implemented at Meharry a thing I call the sample history, which is also the same algorithm that the American Heart Association teaches for ACLS now. And it's one that we actually use in the pre-hospital care setting, even as early as the early 90s. We were using that when I was still working in the field. And basically it's subjective allergies, medications, past medical history, past surgical history, past social history, last meal, and then events leading up to the event that they're presenting to today. And I use that as a guideline, and I've created a sheet, that the students fill out for every consult and every patient that comes through my clinic or through the GPR clinic. And with using that, you get all the patient's medications and you get all of the patient's medical history that they disclose. And, I teach people all the time, it's convenient that my last name is House, and, Hugh Laurie made a heck of a killing with, House MD. And I always tell people, I tell students that they'll bring a patient in and they'll give me this history, and I can see out into the clinic, like where that patient is. And I'll say, you're telling me that person doesn't smoke cigarettes, never takes a drink of alcohol, and does not use any recreational drugs? And they'll say, yes, that's correct. And I'll say, okay, come on. And then I walk in the room and I go, all right, when was the last time that you used drugs? And they go, about 2 hours ago in the parking lot when I got to the school. And I'll say, okay, well, thanks for being honest with me. But, cocaine would preclude us doing anything today as far as oral surgery. So we're going to need to have you stay clean for a few hours or a few days, and then we'll get you back and get you reappointed. And it goes fine. But a lot of times the students, they aren't really interested in being a detective. And sometimes you really have to be a detective and kind of drill down on these things. And one of the things that I try and reinforce to them, and I'll tell them, is, you're coming here into this clinic that I'm running, and you want me to sign off on you to be able to go execute and complete a surgery on a patient, that's a stranger to you effectively. And you don't know everything about every medication that they're taking and every medical condition that they have. And these aren't things that are necessarily obscure. These are things that we see all the time, like, DVT, have a history of DVT and they're on Plavix now. Or, it's a person that has congestive heart failure, and they're on a beta blocker and they're on a diuretic and they're on an antihypertensive of some sort. And then maybe also, like a Coumadin or one of the new generation anticoagulants. And, I'll say, with this patient and their blood pressure being 190 over 100, if I said, yeah, let's go ahead and do this full mouth extraction of their remaining 14 teeth. If I let you just run and do this, 3 hours later, when you're completing this procedure, they might have exsanguinated in the chair or gotten really close to it. And I said, and then we have to like take them from here and wheel them over to the emergency room and admit them to the hospital, and they're going to be in the unit, and that's not acceptable. So here's why you have to be Johnny on the spot with these things and understand the implications of what we're doing, which again is surgery on somebody's head, and understand where that can go wrong and where things can go off the rails. And if people are giving you this information, or you can see it, with your own eyes, you have to be able to assimilate that information and figure out where the train can possibly go off the tracks and then prevent that from happening. And sometimes that's as drastic as saying, we're not going to do this procedure today at all until I speak with your physician, or we do some blood work or some lab work, so that we have a little bit more information and actionable intelligence, so that we can make an educated decision regarding your surgical care. And, a lot of times that's not what students want to hear, because they're trying to, get this patient a dentulous so they can get them to the pros clinic and get some dentures in them. But, I also have to act in the best interest of the patient, of course. So that's the priority, is we're trying to make everybody go home safe at the end of the night.
Another stressful thing is pre-meds. I swear, if you go to a group practice and there's 4 dentists, they all think there's 4 different pre-med protocols for it. And it doesn't help when they're always changing it and changing it and changing it. Where are you at right now with the pre-meds?
Okay, so for cardiac stuff, pretty much the only thing that I'll pre-medicate for, unless the physician orders it, and sends a letter, in which case I'll tell them, you go ahead and prescribe whatever you feel is appropriate. And I'm fine with that. If they don't, or the patient, is maybe years out, or, is a poor historian, or hasn't followed up, or whatever the case may be, if they've had valvular surgery, either replaced with a porcine valve or a mechanical valve, then I will always prophylax them appropriately with 2007 American Heart Association guidelines, which is, basically a gram of amoxicillin or 600 milligrams of clindamycin.
The other pre-med is, and this is a dispute in many group practices, where someone will say, well, that's too infected a touch and they're swelling and we need to put them on antibiotics for a couple of days. And then the other guy's like, well, you know what would be the best thing is to get that tooth out of there and get all that pus out of there and blah, 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 blah. And you got 2 good doctors who are old, and they see this 2 different ways. How do you weigh in on that?
I think... I always think that it's easier for our body to begin to heal itself without the infected, the necrotic material there. And the way I think about that is if you came to me and you said, Sherman, look, I got a huge sliver in my hand today doing yard work. What do you think of that? And I'll say, like, wow, look at that. Like there's pus coming out of it. It's red, it's hot, it's angry. Howard, let's give you a couple grams of Keflex. And, we'll wait about 3 days or so, wait till this thing gets real hot and angry, and then we'll pull this sliver out on Monday. How's that sound? And the thinking past that is usually has to do with the acidity of the tissue and being able to achieve profound anesthesia. So a lot of times people will say, well, if this tooth is really hot and there's a lot of, acidotic tissue there and it's really pussy, then what we'll do is, I&D it, stitch a drain in, and then we'll get them back a few days later to extract the tooth. And that's, I'm okay with that. That's a kind of a long walk for a light snack, but it's okay. One of the ways that I'll usually do it is get around the acidity of the tissue by changing up my local anesthetics to something that has a pKa that's more amenable to, a lower pH. And I can usually get profound anesthesia by either doing that or just going more superior with my block. And if I do that, then I can get them profoundly numb, and then I'll do the IND, suture the drain in place, and take out the fugitive tooth, all in the same visit. So I really don't like people to, leave with something that is, effectively a lit stick of dynamite with an unknown length of fuse hanging out of their mouth.
The young kids that are still in dental kindergarten school, they're going into the fall season now where, it's Halloween, then Thanksgiving, then Christmas. Is it an old wives' tale, or do you think we have a lot more emergencies and trauma in the holiday season than in other times of the year?
I think it's absolutely true.
Yeah.
And I always joke and I say, I think I misspoke before. I think I said 1 gram of amoxicillin, but it's 2, just to be clear. But yeah, I always say that the number one, cause of dental emergencies during the holiday season, which I count as starting in, right about now, mid-October, is food injuries. And, whether it's, I haven't eaten a Laffy Taffy since last Halloween, and then I eat a Laffy Taffy and rip some fillings out, or break some cusps off of teeth, or, people at Thanksgiving always seem to be like gnawing on bones and something bad will happen. So yeah, I definitely think that, it's a situation of half karma. And then also, when it's least expected, you're elected. So, when you are, got the station wagon packed up and you're ready to, close your office in December and leave town for 10 days, that's when that emergency is going to just show up through the door. And yeah, I think that the holiday emergency is a real thing. And I think it's going to be worse this year than it has been probably ever in years past, because there's been such a I don't know, for lack of a better term, like a cease and desist placed on preventative care and, treatment planning. Now, there's so many things that I see in our clinic every day that the patient was made aware of and treatment plan, in mid 2019 or early 2020, that, with COVID kind of shutting everything down, sort of just nipped that in the bud. And these people never got definitive care. And now we see these teeth that were, had a small periapical radiolucency, back in February. Now they're coming in, and eyes swollen shut, or, we've got swelling down into the neck, things like that. So things that could have been fixed easily before, have now turned into major problems. And I think that that's going to be a bigger issue this year, because people were just like, man, I'm not working. I can't afford it. I don't have time. Like, I'm working 2 jobs and driving for Uber Eats, and I don't have time to get to the dentist. And now this kind of thing is going to really sneak up on them. And then, it's a national thing, dentists are half closed for the month of December. So it's just the way it spills out on the calendar. So yeah, I think I do think that is true, that they are always, emergencies are always worse around the holidays. And I think this is going to be the worst one we've seen yet.
And another thing I want to tell you kids, think outside the box. I mean, I've coached people for 30 years where they came out with a bunch of student loans. They didn't come from a family with money. They don't know what to do. And I say, okay, well, the stats are 11% of the towns in America don't have one dentist. Obviously, these are small towns of 1,000 or 2. But I have done this and successfully several times where I tell a kid, well, just go find the mayor of that damn town and tell him you'll go to this town of 1,200 people. Because remember, whatever the small town is, it's 1,000. The draw is another 1,000. So you need a dentist for every 2,000. So a city of 1,000 that doesn't have a dentist has got 2,000 people. And they've literally said, well, if you go to the First Street in Maine, half the buildings are closed and empty or whatever. And the mayor gave them a building, so, well, you
Yep.
can have that building. So now you got free land and building. And then the bank in the town, well, hell yeah, they're going to give you a signature loan. You live there.
Sure.
But I mean, you have no competition. I just think it's a great way to go. But one of the problems in that small town is you're kind of, if you're the only dentist in that town, there's probably no emergency center, there's no hospital, and you get a lot of stuff. And then I practiced for the full spectrum. In the 80s, the doctors were the bad guys because grandma's dying of cancer and they won't give her morphine or pain med. And why are you worried about grandma being a drug addict when she's 80 years old dying of cancer? You doctors are too mean. So we were the bad guys in the 80s, so we started giving a lot more opioids and pain meds.
Yeah.
And now we're the bad guy and we can't go back. And one of my I'm going to ask you about this because I know you worked in a small rural GP practice for a while. My rule just avoids a lot of the problems is I tell them I can't give you any pain medication unless I did something. So if you really want pain med, well, then you're in a lot of pain. So let's pull the tooth or do the root canal. But I'm just not going to give you antibiotics and a pain med because you got to go drive for Uber Eats in 2 hours. I mean, if it's really an emergency, does that work for you? Is that a good in out or is that
Yeah, and one of the things that I have seen, both anecdotally in person, and then also there's a good basis in the literature to support is the use of Tylenol and ibuprofen complex together. And there's people that alternate them, and there's people that take them, or practitioners that recommend taking them together. I think that's a great way to go. And we see corrections patients from facilities all around Tennessee 2 days a week. And, those people aren't prescribed narcotics. Like narcotics don't exist in state prisons. That's why a lot of people of those folks are there in the first place. So, we do full mouth extractions, we do orthodontic surgery, and on a regular basis, like I'm talking 40 cases a month on corrections patients. And they're treated with, Tylenol and an NSAID of some sort, and with great effect. And so I think that there's a definite argument to go towards that. There's a lot of offices here, in Tennessee, where opiate abuse is a huge problem, and they've gone, narcotic free completely, and that's what they do is the combination of the Tylenol and the NSAID, and I think that's okay too. But I'm with you. I always tell people I do not give narcotic pain medication unless I've spilled your blood, and the only way I'm doing that is, like you said, with some type of intervention. And so that's my line in the sand. I also check. We have a database here called the Tennessee Controlled Substance Monitoring Database, and anybody that I contemplate writing a controlled substance to, I run through that just to make sure that they're not in a pain management program already, and a lot of people are. So it's I don't want to get on the state's radar for any of that.
Yeah, and I just want to make one comment about the opium war, and a lot of people thinking how we're in the middle of a pandemic and all that kind of stuff. Did you all forget the opium wars in China, a century ago? I mean, when people say it's a new thing, I'm like, yeah, if you've never read history. I mean, some of the reports when the British got to China, that a third of the entire country was just growing and smoking opium and all that stuff. I want to go to another drug because, like you alluded to earlier, they'll tell you if they're on PenVK or Coumadin or whatever, but they're not going to tell you they're on meth, and that's another big one. If he's young, he's nervous about oral surgery, and he's afraid that maybe this person's on meth. What are you thinking when you have a toothache and you're going to go in there and do an extraction and you're thinking it's not on the chart, but this guy might be a meth addict? What's running through your head?
I look at it, I'm looking more for systemic stuff. I'm not just isolating it to what I see intraorally, because, I mean, um, rampant decay secondary to drug use of any kind is almost indistinguishable from like someone that has a 3 or 4 liter a day Mountain Dew habit, and Mountain Dew was invented in Tennessee. So there's a lot of people here that take full advantage of that. And it's not unusual to go into an operatory here to meet your patient, and they've got 2 1 liters of Mountain Dew, one in each hand. One is empty that they spit their, tobacco juice into, and the other one is full of Mountain Dew that they're drinking. And when you look at these cases, that, the way that I determine is, a lot of times just by their behavior, because people that are, methamphetamine addicts, or regular users, they definitely have a pattern to their mannerisms and their behavior and their affect and the way that they speak and interact with you. And that's, they also have a lot of times, there will be hygiene issues and everything else. So you kind of have to consider the whole patient, of course, like you do for everything, but you have to be specific and look for those indicators that might make you think that something is afoot. Now, I'll tell you, I have seen a tremendous amount of patients that are on Suboxone or Subutex or, some version of that for the purposes of opiate cessation. And that drug in and of itself, where you maybe wouldn't normally see the rampant decay that you see in people with that are using methamphetamine. You imagine this person's on opiates, so there is a parasympathetic enhancement there, and you will see these people have xerostomia. So because they have xerostomia, they're unlike the methamphetamine people that are drinking the Mountain Dew and the Monsters, maybe these people were doing that as well. But a lot of times you'll see the same kind of decay, but it'll be in a not generalized fashion. And with speaking specifically about the Subutex film or Suboxone film, it's a dissolvable sheet, almost like those Listerine breath saver strips, that were kind of popular a few years ago at all the conventions. It's that treated with a drug. People put it into their buccal mucosa and it dissolves. And I don't know what it's made out of, but it sure does a number on, teeth on the people that I've seen use it. And it always seems to be, close to major salivary ducts. So, you'll see it just rampant decay, anywhere close to the Stenson's ducts, and then, in the sublingual as well. So it's odd. And, I think just by getting a really thorough medical history, and then you kind of have to compare it. If you have a person that has generalized decay and odd behavior and sores on their face and on their arms and on their hands, and they're 16 years old, and you're looking at no restorative teeth in their mouth and thinking, full mouth extraction and dentures, that's I would say it's safe to err on the side of caution that even if they told you that they're not a illicit drug user, you kind of have to assume that they are until proven otherwise. And of course, you can also get a lot of that from vitals too. You can get pretty impressive hypertension just off of cigarettes and energy drinks, but you can get a really impressive number off of methamphetamine plus Monster energy drinks plus cigarettes. So, blood pressures that would be, considered an acute hypertensive crisis under some situations. So, yeah, I always have, really highlighted to the students, like, what this person's telling you and what I see when I look at them, those stories don't coincide. So there's a piece of the puzzle here that we need to look into further. And a lot of times, I'll tell people, like, look, like, I'm not calling, the Metro Police to come over here to get you. Like, I could really care less about what you do in your free time. What I'm trying to do is best guide your healthcare so that I don't give you a medication that's going to cause an interaction that could result in your death. So please be honest with me. And then usually they'll go, oh, okay, well, in that case, yeah, I smoked crack cocaine, or I did, a couple hits of ice like 2 hours ago before I drove in. I said, okay, great. Thank you for telling me. We'll, delay the procedure for a couple days and get you back in when you're sober and get it done.
I want to go back to Mountain Dew because that was a very interesting product. During Prohibition, the bootleg was Mountain Dew. So when they brought Mountain Dew to the market, that was already the brand name. But what's interesting is they use citric acid instead of phosphoric acid. And I know a lot of people say, well, Coke has a lower pH than Mountain Dew. Coke has a pH 2.5, Mountain Dew's 3.1. It's not really that. They call it titratable hydrogen ions. Long story short, citric acid can donate 3 hydrogen ions, whereas phosphoric acid can donate 1. And it's just a bad combination, and you start mixing that stuff. I want to go some more specific questions. You promised me an hour of your life. I'm 10 minutes over. Can I go into some overtime?
Sure.
Any thoughts or tips on the dreaded dry socket? And is it still? We were told it was 3 variables: woman or smoker, woman, birth control pill. So 2 of them is woman birth control. Is that still a thing, or is that because I'm at the age where a lot of this stuff I learned 30 years ago, like even the 3 laws of thermodynamics. Now there's 4. I mean, but
Sure.
Rant on dry sockets.
Okay, so the first thing that I always tell students is the longer that the periosteum is exposed to the air, the better. So if I can get a procedure, open, shut, and sutured in 90 seconds or less, then I'm happy, patient's happy. The chances that I see them back for a postoperative complication is very, very low. The other thing along with that is that I always tell people, like, absolutely no smoking, absolutely no drinking through a straw, and absolutely no spitting. And those 3 things, I think, go a long way towards it. And in my experience, it's probably 90% of the time when I have somebody that has a dry socket, they're a smoker. So to kind of hedge my bets towards that direction, I will, always work to get primary closure on a tooth like that, and then on a smoker, and then I'll often put gel foam, or Surgicel in the socket as soon as I do it, just to make sure that stays planted there.
Another thing about access to care, affordability, availability, I've been told point blank, well, I'm working at this, well, it might even be a volunteer deal. It might be St. Vincent de Paul, something, or, some church. And they'll say, yeah, but I would have had to have a CBCT. And I kind of cringe because I sit there and think, okay, well, we didn't even. I remember when the greatest new thing in oral radiology was on the pano where they put an R on one side and an L on the other. And I thought that was the greatest thing that ever happened in radiology because the patient looked at it and says, is that my right side? When is a CBCT, when is it the standard of care? When can you not pull a tooth and be that emergency room doctor, get them out of pain, pull a tooth, without having a CBCT?
The only time that I really even think about those is, as far as, from the public health aspect, is if I see something that is really obvious, large pathology on the pan. And if it is something where I can actually palpate, expansion in the arch. If it's something I can, palpate expansion in the arch, or something that where it kind of hits me with this is some type of pathology, then I'll say, hey, let's go ahead and get a cone beam. We have one across the hall, just to sort of rule that out and see where this is going, because, it doesn't make any sense to yard out a couple teeth, if you could also do that and, enucleate, assist, or, we see a pretty good amount, probably half a dozen a month, like Dentidra assists, probably half a dozen a month, OKCs, the kind of, and amealoblastomas as well. So, we see them, and that's kind of when we look to get some advanced imaging. But probably 98% of everything we do off of a pan with right and left markings on it.
I want you to address this. There are, when you lecture around the world, irrigation protocols, that's what I love the most. When people say they love architect, what they're really saying to me is, every human lives in a home, and it's neat that all 8 billion people need a home, and they all make it different, down to the details of the bathroom, the sink, the plumbing. And I notice when I'm in some other countries, after every extraction, they have a very exorbitant protocol. Like, first they'll rinse the socket with Preparedness, then they'll use hydrogen peroxide, and is post-surgical irrigation part of your protocol?
It is, yeah. We rinse and irrigate with Preparedness just about. I mean, every time we do a procedure, and I think that's especially for our population. Our population, medically indigent. Lot of polypharmacy patients, a lot of systemic illness, a lot of immunocompromised people. So anything that we can do to kind of put the odds in their favor to allow their bodies to do, a better job of catching up to repair and remove any further pathogens, I think is beneficial.
And now the new thing is bone grafting, and there's a lot of people that it's convincing these young dentists that if you extract a tooth, you got a bone graft. What's your thoughts on bone graft? When to be or not to be? When are you bone grafting?
If I'm going to be absolutely placing implants in the future, then I think that it bears some use. Somebody the other day I saw was routinely bone grafting for third molar extractions, which just seems like, nickel and diming somebody, charging $250 per site for a graft for something that if you just left it alone for 6 months, it's going to fill in and be absolutely normal. And what are we grafting for? Like, there's so much bone, in the proximity of the mandibular thirds, especially on the buccal, that it's not going to make a difference in the world whether you graft that site back or not. So if we're really concerned about ridge preservation and socket preservation and putting something there, in the immediate future, then I'll graft. But in the public health setting, we can't justify the cost. And patients certainly aren't going to pay it. We have patients that gripe about getting a tooth out for, an exam, an x-ray, and an extraction for $70. So, if we said, yeah, we could do that, we could also graft the site back for, $150 or $200. Most people would, scoff at us and stomp out the door.
Piezo unit, is that standard armamentarium or is that a must have or what?
I haven't used one, in institutionally. I mean, I've used them before in private practice, but I don't think it's an absolute no. I don't think that it's something that you have to use. No.
Yeah, I agree. It's a nice thing, but you don't have to have it. A lot of the surgeons, and we're both bald heads. I'll
Sure.
bring that to your attention. Man, when you got a bald head and you're banging into that overhead light and then, things like that, are you still using the old-fashioned overhead light and banging your bald head against it, or are you using a surgical headlight?
I'm probably about 50-50. If I'm going to do something planned, I wear a light. If I'm going to do something spontaneously, to get a student out of the ditch or a resident out of the ditch, then I'll just go in and use the operatory light. But I'll tell you, enough students and residents have them now that a lot of times I can be like, point your face over here, and just have them, hold their over my shoulder or, close to the proximity. And those LEDs, they have got such a tremendous amount of spill that you can see very, very plainly what you're trying to see. But yeah, that's how I do it.
And I want to tell the dentist that in 32 years, I've had 2 of my dental assistants become dentists. And you know what the only thing they both had in common? Well, they were both girls. They were assistants. They were girls. But when I would be doing surgery, they'd always be bumping their head. And then when and sometimes I just like have to take my hand up there and put my hand on their head and just like push their head back in. So I want to tell these dentists, when you got a dental assistant who's actually banging her head on your head, she's so into this. I mean, she's trying to see. And I'd say to him, I said, Elaine, you bumped my head 5 times. And she goes, I know. It's hard to see. Can you move your head back? And I'm sitting there thinking, I'm the dentist, so it's when they're really fighting to see, that's a really good thing. Another thing, put your dad hat on. Some of these people, when they're coming out of school, they just always think they have to section every tooth before they even start doing anything. So rant on sections. What makes you think I'm going to section this first as opposed to luxating it and working it that way?
My big thing is I'll take into consideration the history of the patient, and their overall health and exam. But I also look at ankylosis. Like ankylosis is one of those things that, can really, really make a relatively straightforward extraction, into a real humdinger. The other thing with ankylosis, and, kind of goes along with it, is long-standing endodontically treated teeth, that don't have a periapical radiolucency. If you end up having to take those out, a lot of times it's a fight. And, if it's say a 19 or a 30, that's been there for 25 or 30 years, maybe it's got silver points in it even, and you're like, having to go and get it, and it's ankylosed, like section is going to be the least traumatic way to get it out of that patient.
Now I'm going to get you in trouble. I'm going to ask a question so controversial, there's no way you could answer this without pissing at least half the people off. England did a study about 5 or 10 years ago. They were looking at IV sedation deaths, and they're rare. But they did call out the dental community that even if it's only 1 out of a million, the dentists were, 2 out of a million. And I find what I think is very interesting is looking at, we're all the same species, we're all treating the same decay, we're all the same patient, they all eat sugar, regardless of what you think when you're little. I'm like, we believe when we were little that in India they were all vegans and ate the best. Oh my God, when I went over there and lectured, I mean, when you go to the dentist's house, you were met with grandma with a whole tray of sugar cookies. In fact, I'm almost ready to say that India might eat more sugar than Americans. I mean, it's all the same thing, but they do things slightly different. And in America, you can't go in a hospital and do the IV and the bypass. You can't do the IV. I mean, in every hospital in America, it's separate. It's like you do the IV, surgeon do the surgery. The only place I see it is mainly in dentistry. Joan Rivers is a classic example. She just went in to have a little nodule done, no big deal, but one of the most famous comedians of the time died from IV sedation. I noticed there's only 2 publicly traded dental, there's 3. 2 in Australia. There's 1-300 Smiles and Pacific Smile, and then Singapore has one, Q&M. And I've met with all 3 of those founders, and in order for them to go public, the broker said no IV sedation under 18 over 65, because they looked at the risk analysis and they said no, 18 and under, no way. 65 under 18 over 65 was the majority of the mortalities, as the way Wall Street brokers saw it. So the question is, When I hear these dentists say, "Oh, I'm going to go to this weekend course in a hotel and I'm going to start doing IV sedation," I'm like, God dang. So for many, many years and still to this day, in fact, I just had dinner with them a couple of nights ago. These oral surgery, these medical malpractice, they send me their month-end claims, right? Anytime it's the max, 1 million, 3 million, they all have the same thing in common. There's an IV and it didn't go well.
Right.
I just don't believe in it. I think if you want to do dental, hell, it's even a specialty, dental anesthesiology. But I'm telling you, you're talking to a lot of dentists right now who do IV sedation while they're doing the dentistry. What are your thoughts on all that?
Yeah, I mean, I am a fan of IV sedation just because I think that there's a lot of patients that just can't tolerate, even enteral sedation or local anesthetic, just straight up local anesthetic and getting work done. Now, granted, most of the ones that I do, are relative to exodontia cases. I don't really have much to do with IV sedation with restorative or endo or anything like that. I have friends that do that, but I don't fiddle with that. So I think you can be very there. There's a few different ways. Like a lot of people that are experienced with IV sedation, hit the patient with a big huge bolus of opiates and benzodiazepines and antiemetics, get them real snowed and do the work, no problem. And that probably works good for 75% of the patients. And you'll always have a certain percentage that falls outside of that, where regardless of the amount of drugs that you give to them, it's just combat ineffective. Like you're not doing any good at all, and you end up aborting the procedure, and it just turns into bad feelings and refunds and everything else. So I think you have to be really, really cautious with your IV sedation cases. I don't like to do IV sedations on anybody that is above an ASA class 2. If it's somebody that's an ASA class 3, then a lot of times then we will take them to the operating room at the hospital and do that, in the full surgical suite with an anesthesiologist and run it that way. But, of course, that boils down to the economics of it too. And, working at a school like I do, there is a bit of a break than it would be, in private practice or at a surgery center or private hospital or something like that. But I think that I think kind of like many expensive CE courses that are available in dentistry, IV sedation is like a $12,000 or $15,000 course, for the 60 hours or what the requirement is. A lot of times people do that and they go, okay, we're going to set up the whole practice, based around IV sedation model. Or, I invested all this money into a CIREC and CIREC training. Now we're going to, base the practice all around that. And it kind of turns into the, when all you have is a hammer, everything starts to look like a nail. And you start trying to do, IV sedations on somebody who's a little bit nervous and has, some buccal pits and an MO on 14 that needs to be done. And they're just anxious, and you do it because it increases the profitability of a otherwise low productivity procedure. But at the same time, could you manage that just as well with some, iatrosedation, hypnosis, and some nitrous oxide, and maybe a little, benzodiazepine the night before for anxiolysis? I mean, I think you can. I've worked on, thousands of special needs patients using exactly that. And, these are people that are, not, normally amenable to that kind of thing. And it works fine. It just depends on how you treat them. And I always call it like using the Jedi mind trick. If you have the capability to do it and you're good at it, I think that it's best to use the just kind of like we use the minimum amount of radiation possible, we should use the minimum amount of sedation and local anesthetic that's possible. It just doesn't make sense to like hit everybody with everything all the time and then just kind of, ride the averages and hope that you're going to be able to, dodge that bullet that's coming your direction at some point, and have the case that's just going to be, somebody that ends up having a bad outcome that could have been handled, easily by a less invasive method.
Another thing from this coronavirus pandemic, now there's people saying that after you pull a tooth, you can't give the patient the tooth. It's a biohazard. It's not following OSHA, but the patient wants their tooth. I mean, it's a body part. Where are you standing in on that now?
I've never really been a big fan of that, just because.
A big fan of what?
Giving away the teeth that I extract.
Yeah.
Just because I think there actually is a regulation against that in Tennessee. But aside from that, what I don't like is, even if I like took it, wiped it down with bleach and then autoclaved it, in a small bag and, signed my name on it, wrote the patient's name and date, and I give it to them, they'll open it up, roll it around in their fingers, touch every pen and clipboard in the office and the doorknob on the way out. And that just kind of grosses me out. And so just from a hygiene, hygienic perspective, I just don't like that. And it just doesn't sit well with me. But I mean, aside from that, like philosophically, I'm not opposed to, giving patients their body parts back, as long as it's, I do it to kids sometimes, especially, if it's a little kid or some ortho extractions or something like that. But in general, I don't.
Well, I'm going to play devil's advocate on the IV sedation because, I have 4 kids, and my gosh, when you go in the emergency room in the middle of the night and you decide you need an IV epidural, they just paid someone and they show up out of nowhere. There are, if you're, now granted, I'm in a big city. Phoenix is about 1 million people, but the metro is 3.8 million, and you can page an anesthesiologist, to your office. I don't know, I would do that. One last thing. I know it's late there. It's 5:30 here. What time is it in Nashville? Is it 7:30?
7:30, yeah.
Yeah. Oh, by the way, I think that's interesting where did you see the position statement on the American Academy of Sleep Medicine? They're getting ready to change the daylight savings coming up, and I thought it was pretty cool how the daylight savings time position statement by the American Academy of Sleep Medicine says you guys should eliminate this. And I'm telling you, the research is clear as a bell. We've been living on circadian rhythms forever. By the way, the dinosaurs didn't go extinct. We still have birds, and they've been flying around on circadian rhythms since the asteroid deal. And they're the Academy of Sleep Medicine, I thought it was very good. But I imagine in the middle of a pandemic, an election, an economic collapse, racial tensions, I don't think daylight savings is going to make it high up there. But one last question I see is about, again, I love to see variants. I think dentists are all smart. They all were trained in math. Applied math is physics. Applied physics, chemistry. Applied chemistry, biology. Applied biology is dentistry. But in the oral surgery community, you guys use a lot more electrical handpiece drills, and the dentists are using air. And in fact, there's dentists who, they'll know that you caught them or something. They'll say, "Oh yeah, man, I pull a gazillion teeth a month." And I'll say, "What electric handpiece do you have?" They're like, "Ah." So they're doing it. They're doing it. I mean, they're removing bone with a high speed, moving bone back there. How bad of an idea is that, or is it? What are your thoughts on that because of air embolism possibilities and stuff?
Sure. As long as you're using a rear exhaust handpiece, it's not an issue. I mean, I have I use an electric, but I also have some backup, like NSK brand, rear exhaust surgical handpieces, that have a contra angle head on them that are designed to be used for oral surgery. I don't think they spin at, the same RPMs that like an operative handpiece would spin at. And they're also, they also have a spindle in them that will stabilize a longer, a surgical length burr better. And so, as long as you're doing that, I think that's fine. I've seen a case with my own eyes while it was happening of an air embolism when I was a dental student. It wasn't a patient that I was doing the work on. It was a patient that I was watching, have the work done on. And while this was occurring, I noticed that this patient's eye, like periorbital tissue, just started to swell up like a cartoon. Like it reminded me of that scary monster martial artist at the end of Big Trouble in Little China. You remember back in the 80s, like it just instantly started to inflate. And I, hit the guy on the shoulder and I was like, stop, stop. And, just like you'd read about in the textbook, she had subcutaneous emphysema, and, was immediately sent to an oral surgeon for follow-up, and it all turned out fine. But the moral of the story is I think it's a lot better to just not get there in the first place. If you're going to do surgical extractions that necessitate the use of a pneumatic handpiece, make absolutely positively sure that it's a rear exhaust handpiece. And, I always tell people, they'll say, is this a rear exhaust handpiece? And I'll say, like, hold it up in front of you, step on the rheostat. And then they do. And I said, do you feel the air hitting you in the face? And they say, yeah. And I said, that's the rear exhaust. So if you have that, I think that you're okay. But, I really, having used pneumatics and now having used electrics, I've really been spoiled by electrics. And I think that, there's millions well, not millions, probably thousands of posts on Dentaltown about the benefits of using electrical handpieces, and all the stuff that applies for operative also applies for oral surgery and exodontia. And I think that, electric handpieces are just so great. And I love just the control, and having a true, 40,000 RPM available to me to cut bone with inline irrigation just makes everything so quick and so easy and so predictable. And, when you cut a flap, you see guys like, Ben Johnson and Jason Auerbach, Bloody Tooth guy, doing these great GoPro surgeries on their Instagram pages, using both pneumatics and using electrics. And, the end result is the same, but the effort involved and the feel for the operator, I think, I really enjoy electrics as opposed to the pneumatics.
Well said. And just a little, thank you so much for this. One last question. A decade ago, you're in Nashville. It was flooded. It was devastating. Is that all repaired and behind you, or is there still damage from 10 years ago?
The flood, by and large, most of that stuff was repaired. The mall, you've been to, I'm sure, the Opryland before. There's dental meetings that happen there, by the dozen every year. That place was destroyed. It was under, I think about 10 or 12 feet of water. That's all, been restored and is completely back to normal. I can say, though, that, we had a tornado that came through here approximately around March 2nd of 2020 that really caused a ton of damage throughout the state of Tennessee, not just here, but also in Donaldson, some of the outlying suburbs of Tennessee, and even as far east as Cookeville and Baxter, which are, kind of up the mountain, heading towards the Cumberland Plateau. The Upper Cumberland. And then immediately 2 weeks later, the COVID stuff started happening. And so a lot of the rehabilitation and rebuilding efforts instantly got shut down because of that. So we do have a lot of the city and a lot of the area up around Meharry in North Nashville that is still in a huge amount of disrepair, and businesses closed forever. First because of the tornado, and then not being rebuilt and gone because of COVID. So yeah, the flood is a distant memory, but the tornado is still very recent here.
That Operaland USA, there's two things I got to say about it. Number one, I remember the first time I ever lectured there, I called the front desk like 5 times because I just loved hearing him say, Operaland USA, may I help you? And it was just so cool. But anyway,
right.
Oh my God, my mom's to getaway trips when she wants to get away. I send her to Operaland USA. She loves sitting in that indoor deal, and then she loves and the other ones in Tennessee, Chattanooga. There's a hotel that's in a train car. And, she just thinks that's cooler and stuff. But when I go there, I don't stay there. I always just stay at Dolly Parton's house, and that's my home getaway. But hey, thank you so much for coming on the show. And man, if you ever got time to do an online CE course, it'd mean the world to me because you're so knowledgeable on it. And again, it's the redheaded chip styled of all the dental specialties is dental public health, and it's just embarrassing when 8.5% of our patients end up at the emergency room while doc's out there, on a 3-day weekend at the on a 4-wheeler, and we need to get to a minimum level that if you go to a dental office and you're in pain, someone there can triage you. Because the emergency room, I mean, they can't even take a PA. You might as well just ask them why your car won't start. They're not equipped for it. And dentists got to get to the level of basic public health triage. And I think, my God, my favorite procedure is an extraction. I mean, it's instantly out compared to a 2-year Invisalign case. I mean, God, it's just like hitting a home run. I mean, it's right there. You just saw it happen. I think oral surgery is the most instant gratification, and orthodontics is, my God, it's so long and time consuming. But Sherman, thank you so much for coming on the show. It was an honor to podcast you, and I hope I didn't keep you up past your bedtime.
No problem at all. Thank you for having me, Howard.
All right. Have a great day.
You too. Take care.